Can you see the screen?
Yes, sir.
Fine. So let us go for that. We have seen so far is depression what it is, and there are many etiological factors are known what which can cause it. It is not clear what it is. I told you about one book that is Stephen Starr that it shows about various reasons, various factors which are causing depression. Long back I told you there was one theory which was proposed, even we asked question on this, that what can be the reasons, and in that we have found that there is a decrease in the biogenic amines or biological amines, and therefore most of the drug when we find which are working in the depression, we find that they are supposed to elevate the concentration of these amines, whether it is noradrenaline or whether it is 5-hydroxytryptamine or dopamine. So when most of our drugs are aimed, or they are basically thought to increase the action. However, one important problem was there, or example tricyclic antidepressants are there which are causing the they are reuptake inhibitors. So because of the inhibition of reuptake, there is an increase in the levels of noradrenaline in the synapse. But everything is there when it is causing it instantaneously, whenever it is reaching to synapse, and it can cause increase in the concentration. The people who are not happy with this amine theory or monoamine theory, they say that then why it takes time, because the thing, example, most of the drugs, particularly if we take tricyclic antidepressants, they take around 3 to 4 weeks to show the action, antidepressant action, not less than 3 weeks. So if it is taking 2 to 3 weeks, then why this? Because if people say that the etiological factor is what, that it is because of the decrease in the amine concentration, or there is a damage to the neuron which are producing these biological amines. So whatsoever it may be, if it is there, then why it should there? Why the neurotransmitter, the agent or the drug which are increasing the neurotransmitter level in the synapse, if it was so simple that it is because of the decrease in the monoamine neurotransmitter, and if we are increasing it, it should have increased immediate, but it is not happening. So there are many things are going on, many studies are going on. Then scientists has found whether there are any biological markers are there or not, and very interesting observation, they have found that there is increase in the cortisol formation, and it does not get suppressed. Normally if we give exogenous corticosteroids, then because of these corticosteroids there will be depression of HPA, that is hypothalamus pituitary, this adrenocortical axis, we call it as a HPA axis, hypothalamus pituitary adrenal cortex, and that axis is there, that means we know that is a negative feedback is there. So when exogenous corticosteroid is added or it is present in blood, it will cause feedback mechanism to hypothalamus, that will cause decrease in the corticotropin release. Because of that, this will cause decrease in the ACTH, that is adrenocorticotropic hormone will be decreased, and thus it will cause decrease in the production of corticosteroids from the adrenal cortex. However, this is not happening, okay, particularly in the cases of depression. But these results are not constant. In some cases it is happening, in some cases it is not happening. So it cannot be taken as a very true one, because there are many false positive. False positive means there are people which are having this corticosteroid problems, even though they don't have depression, and there are people with depression, we call it as a false negative. That is, in false negative, what is happening is, there are the patient which are having depression, but they don't have any noticeable change in their corticosteroid, or even if you inject corticosteroids, their corticosteroid synthesis falls, it decreases as normal people. So there are many such patients are there, and therefore we do not know. What is there? We have got various scales for that. We have seen DSM earlier. So apart from DSM, we have got many such scales are there which are helping into it, which are responsible or which are helping into various analysis of this. So if we can see this, we can go for that. These are what are various scales. So example of these are DSM already we have seen. Then apart from that, there are many other scales are there. We shall go one by one, and another one is there that is very prominent or very popular one is a DSM 4 or DSM 5 rather nowadays. So these are the latest scale which will show you why there is a depression. And there are many symptoms are there in these patients which can be seen. We will see about how we can diagnose with the DSM scale also. So there are very many such questionnaires are there. These are the questionnaires which will be able to identify various kind of thing. Example of this is mood disorders, or a general medical condition will be there, or substrate induced mood disorders we can have. Example of these are, there are many drugs which are causing it, many chemicals are there, or many other underlying causes are there which are responsible for depression type of symptoms. So this can be endocrine diseases like hypothyroidism or Cushing's disease, which is linked with the corticosteroid hormones. Then dietary status, particularly those who are having anemia, then Wernicke's encephalopathy, severe anemia. In that patient, it is found to have more depression. Certain infections like AIDS, encephalitis, human HIV, mononucleosis, then various sexually transmitted diseases, tuberculosis, then many other disorders like SLE we call systemic lupus erythematosus, and many such diseases are there. Then the substances which are resulting into this kind of depression, which are not drug or not such chemical, example alcohol, marijuana, nicotine, that is smoking or tobacco, that is opiate abuse and dependence like heroin, psychostimulant abuse and dependence like cocaine. This kind of substances can also result into particularly intoxication and withdrawal. Those which are habituated and all of a sudden if they are withdrawn, then we call them as withdrawal symptoms, and as a part of withdrawal symptom, these people can have depression. Certain drugs like antihypertensive like clonidine, then diuretics, guanethidine, hydralazine, methyl dopa, propranolol, reserpine, they are doing this. Now this supports that way to our monoamine theory, because tricyclic antidepressants are there. This tricyclic antidepressant, they causes inhibition of uptake. Because of the inhibition of uptake, there is an increase in the concentration of this monoamine, that is noradrenaline or 5-hydroxytryptamine, and these agents, example of this, most of these agents, they will cause a decrease of the concentration of or postsynaptic effect of adrenergic mechanism. So these are the agents which are there, which are doing it. Example of these are propranolol, reserpine, etc. Hormonal therapy, that is oral contraceptive, then acne therapy like isotretinoin and interferon beta. These are the agents which can cause it. Then what are the questions? You can see these are some of the questions. 5 or more of these following thing. If you take DSM criteria, then it shows what are the criteria they are judging with the DSM criteria. So 5 or more following symptoms have been present during the 2-week period. Earlier also we have seen during when we started with DSM. DSM, or American Psychiatric Association, APA, that gives clear guidelines that for 2 week or in the period of 2 week the results are seen, and if it is consistent, then we can diagnose that yes, there is a depression. However, it should not, because it can be just one time reaction, it can be. So when during show the similar symptoms during the 2 week period and represent the change from previous functioning, at least one of the symptom, either it shows depression in the mood, or loss of interest, or loss of pleasure. So these are there, they are put into questionnaires, and accordingly they are just depressed mood most of the day, nearly every day, whether it is there or not. Out of these 9, at least 5 criteria must be meeting. Okay. Then second is markedly diminished interest or pleasure in all or almost all activities most of the day. Then third thing is significant weight loss when not dieting, or there is no weight gain. So this is another sign. Insomnia or hypersomnia means sleeplessness or more sleep than normal. Then psychomotor agitation or retardation nearly every day. That is observable others, not merely subjective feeling of the restlessness or being slowed down. That means what? One can immediately judge कि the person is showing comparatively more agitatory type of behavior, or responding unduly, or retardation, not at all responding to any provocation. So this is called as a psychomotor agitation. Normal, abnormal response to any kind of psychomotor stimulation. If somebody asks some question, or somebody scolds, then what kind of reaction? Then this is a psychomotor agitation. Then fatigue or loss of energy nearly every day. This will be there. Feeling of worthlessness or excessive inappropriate guilt. Even if the person is not guilty, but will feel guilty about everything which is happening. And this is the guilt which is there. Then recurrent thought of death, not just fear of dying, but rather thinking about death, or accepting death, or going for death. So this type of things are called as a or which is responsive, or which is going towards suicide. These are there. And all these symptoms, they will cause clinically significant distress or impairment in social, occupational, or other important areas. Just a minute. सानी का क्लास घेतोय बेटा मी. हां, बरं ठीक आहे, चालतंय, काय हरकत नाही. ओके ओके. So these are there, and these symptoms are not better accounted for bereavement, or that is death, or etc. After death also people get this feeling of depression, but there is a difference between depression and sadness. Sadness is everyone, almost everyone is having, those who are having good mental status. Then everybody may have that sadness that somebody from their near has lost, is lost. But here it is feeling of almost getting what we can say, that guilt like thing. Suppose somebody dies, people may think, those who are going into depression may think that no, I could not give proper treatment, or I could not save. This is a guilt, or behavior like, or feeling of helplessness, or feeling of uselessness. Okay, now after the person has died, nearby person has died, my life has become useless, and then committing suicide. So this is a depression tendency. So there is a big difference between this. Depression, the person is trying to commit suicide or having thoughts of suicide, is different than that was having sadness. So feeling sad is different, and having depression is different. That has to be understood by the people nicely. Then apart from that, there are many symptoms are there. Those who are depressed, then they have lesser intellectual activity or cognitive activities, and they can have psychomotor disturbances, that is they are slow or retarded in physical movements. their thought process, or they will not respond properly, their speech will not be proper one, there will be psychomotor retardation in these people, and depression may be accompanied by psychomotor agitation manifesting as purposeless restless motions, doing things again without any purpose, like pacing, wringing of hands, outburst of shouting. These are undue agitations which are there, psychomotor agitations. So these are various activities it may have. Now we shall go for some of the scales which are there. Just a minute. So if we go for this, these are various scales apart from DSM-4. There are many scales. We call them as a psychiatric rating scales, and these scales are important in discussion. So how we do it, what are various scales into it. We shall see other scale later, that is schizophrenia, we shall see when we shall say schizophrenia. Now for depression, what are various scales? So after DS, we have seen DSM-4, okay. Apart from that, what are other scales which are available? So example of these are the Hamilton depression scale, that is it is rated by clinician. It is having 17 atom scales, that is 17 scales are there, and if there is a less than 6, it is a normal mood. If it is 17 to 25, then there is a moderate depression, and if it goes beyond 25, then it means severe depression. So this is one important tool, okay. These are the scales. Scales means these are the questionnaires which are given to these patients, and from the answers it will automatic, just like in Google form or examination you people we are taking, and accordingly as per your performance the marks are there. Similarly on that scales will be given for various MCQs, and accordingly these scales will give you various answers. It is used to screen patient for drug studies, and drug studies means whether the antidepressant drugs are effective or not, or whether some of the drugs are causing depression or not, like that, and to determine severity of symptoms. As we have seen that we have graded it. So if the score is 17 to 25, then we call it as a moderate depression, and less than 6 is a normal, but 6 to 17, from 6 to 17 is a we can say mild depression. 17 to 25 is a moderate depression, and above 25 it is a severe depression. So we have got grading of it. So this grading gives idea about the patient status. Accordingly we can decide the treatment. This will help us to finalize the treatment also. It is the standard to compare other depression rating scale against each other. Okay, so if if it is doubtful, then Hamilton can also be used, and DSM-4 can also be used, and on that basis one can make the assessment. Then another one is Montgomery-Ashburg depression rating scale. It is also clinically rated, clinician rated, that is clinician gives this and clinician gets the data. It is a 10 atom 7-point scale. For each atom 0 for no symptoms, 6 for severe symptoms. It is differentiating between all the intermediate grades of depression. It decreases bias in the patient with other medical illness, and it increases the somatization, that is unexplained physical symptoms are there that can be categorized with this Montgomery-Ashburg depression rating scale. Then another is by scientists Beck depression inventory, that is known as a BDI. It is patient rated, means patient can give itself without any clinicians. It is 21 atom scale. 0 to 9 is a normal, 10 to 15 is a mild depression, 16 to 19 is a mild to moderate depression, 20 to 29 is a moderate to severe, and 30 to 63 is a severe depression. Okay, it is standard for depression self-rating scale, and it is objective measure for change in the symptoms as a result of treatment. Then next one is a Zhang self-rating depression. Again, it is also patient rated. That means clinician is not required, patient can give themselves. It is 20 item scale, 4-point severity, less than 50 is a normal, and 50 to 59 is a minimal or mild one, 60 to 69 is moderate, then more than 70 is a severe depression. So it is similar, that is severity rate by frequency of occurrence of the symptoms. It may not be sensitive in measuring changes in the severity of the symptoms. Then other one is known as a PHQ-9, that is patient health questionnaire, that is PHQ-9. So it is also patient rated. It is 9 item 4-point scale for each DSM-4 depression criteria. This is based on DSM-4. PHQ is not 0 means not at all, 3 means nearly every day, score less than 10 means minimal depression symptom, and as it grows then it increases. It is used primarily commonly used in primary care centers to establish the diagnosis of depression and assess severity of the depressive symptoms. Then another are quick inventory of depressive symptomology, that is QIDS-C. It is done by clinician, and QIDS-SR is done by patients. Basic name is same, quick entry of depressive symptoms. So QIDS is the same, but C means clinician and SR means done by patient. So it can be done, there are slightly modified questionnaires. One can done by clinician, other can done by patients. They will be doing the ratings, or they will be doing the answers on that. 60 item scales are there. The score range from 0 to 27, 0 to 5, and accordingly we get it. 0 to 5 is a none, 6 to 10 is a mild, 11 to 15 is a moderate, 16 to 20 is severe, and 21 to 27 is very severe. So this is used to assess the symptom severity and symptomatic changes. This is found to be sensitive to the symptom change. As the Hamilton we have seen, and it has got usefulness in both clinical and research settings. So this is important. This is again one other important one. Then another one is Young Mania Rating Scales, YMRS. It is done by clinicians. There is a 11 item scale, 5-point severity, 11 minimal, 20 means mild, 26 means moderate, and 38 means severe. It is also screen patient for drug studies, particularly when you will study clinical trials or clinical research. At that time you will see that in that what happens is you have to select the patient, and particularly you have to put them the patients of similar, or there should be proper mix. Suppose you are comparing two drugs, one is new drug, one is old drug, and for old drug if you get all the severe patient, and for new drug you get all the mild cases, then it is a biased one. Then you will say that your new drug is more effective than that. But if you have got this kind of skills and or this kind of results, then you will mix it. So some will be mild, some will be severe, some will be moderate, and accordingly number will be almost same, and then similar set of group will be for newer, and similar set will be for the older drug with which you are comparing, and then you will get some proper data. Otherwise this data will not be proper one. Even if you do it otherwise, that all milder to old drug and all severe to new drug, then you may say that the new drug is not good one, because so this is, we call it as a bias. So to avoid bias, we can have the screening of the patient for drug studies, and then determine severity of symptoms and treatment outcome. It is standard to compare other mania rating scales against this. And lastly, we have got mood disorder questionnaires. It is patient related. There are 15 item scales. Score of greater than 7 suggestive of bipolar spectrum disorder. Bipolar is what? There are both poles are there. We are considering one pole here only, that is depression. In bipolar, there is one more pole is there. Sometimes this patient go into aggression, and other time they are into depression mode. So these two things are happening. Just a minute. Hello. How? बोलो ना सर.